Silakan, Prof.
Masih ada Zoom dengan yang barusan dipanggil di atas ya.
Dokter, ya Ibu Lis.
Iya, di sebelah kanan saya Zoom bukan.
Iya. Maaf, ini musiknya tolong dimatikan dahulu ya, Dokter. Ya, iya Ibu Lis.
Iya, Prof. Saya sih siap juga.
Iya siap Ibu, mungkin nggak apa-apa Ibu. Prof masih mute Prof.
Oke, yuk kita mulai.
Baik, izin kita mulai dahulu ya, Prof, Dokter. We'll start our webinar. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Hello, good afternoon, everyone. I am very happy to welcome everyone here at our IROS first webinar of the year 2022. This is a very special one. We designed it carefully and would like to bring a different insight and more depth to our regular monthly webinar. So we feel that perhaps a bird's eye view would be helpful in facilitating all of us to reshift our priorities and strategies among all our daily struggle in fighting cancer. And therefore, we are very happy to welcome every one of you here in the IROS Global Oncology webinar to introduce us before the events of World Cancer Day begins this year. I would like to greet our respected panelists first present today. Yang terhormat Dr. Dante Saksono Harbuono, spesialis penyakit dalam, konsultan endokrinologi, metabolik, dan diabetes, the Vice Minister of Health of Republic of Indonesia. It is an honor to have you here, sir. Yang terhormat Dr. Lisdina Liastuti, spesialis jantung pembuluh darah konsultan, the President Director of Cipto Mangunkusumo National General Hospital. Good afternoon, Ibu Lis. Thank you for your support to us always, Ibu. Yang terhormat Profesor Ari Fahrial Syam, spesialis penyakit dalam, konsultan gastroenterohepatologi, the Dean of Faculty of Medicine, Universitas Indonesia. Welcome, Prof. Ari. We really appreciate your time and participation this afternoon. Also, we want to give the warmest welcome to our partners from the civil societies fighting for cancer and cancer survivors support group. May I say hello to Ibu Samantha Barbara, the president of Love Pink Community. Hello, Ibu. Thank you for joining us. And Ibu Arianti Baramuli, the president of Cancer Information and Support Center, CISC, our longtime partner. Ibu Yanti, a pleasure always to be meeting with you. And Ibu Rahmi Adiputra Tahir, the president of Indonesian Children Cancer Foundation, or YOAI. Good afternoon, Ibu Rahmi.
Good afternoon,
welcome
Ibu Lis. Good afternoon, Ibu Lis.
And of course, we have our keynote speaker today from the WHO headquarters, Dr. Andre Obaui. Hello, Doctor. It is truly our honor that you kindly give us your time and expertise and would like to share with us on this event. And we are very happy that we have more than 460 people joining us this time. Now, even though this is IROS webinar, but not only our fellow radiation oncologists from Indonesia is joining, but also from abroad. Welcome, doctors. And also we see many colleagues from other disciplines, also from the Ministry of Health, the civil societies. So it is very encouraging to see everyone here that we are all in this together, hand in hand, to deliver better cancer control strategies and programs in the future. Now, to begin our session, may I kindly invite our beloved president of IROS, Professor Suhartati Gondowiarjo. Please, Prof, to give her welcoming remarks and greet everyone here. Silakan, Prof.
Thank you very much. Can you see my PowerPoint, Maya?
Yes, Prof.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua, salam sehat bagi kita semua. Good afternoon, everyone. Respected Vice Minister of Health, Dr. Dante, President Director of Dr. Cipto Mangunkusumo National General Hospital, Dr. Listina, Dean of the Faculty of Medicine, University of Indonesia, Professor Ari, our panelists, our fellow colleague from IROS, Indonesian Radiation Oncology Society, radiation oncologists from the region, and globally, I saw that they are also friends from other countries. Welcome. Also, many of our fellow from other disciplines, our pride and joy to have you here. As we all know that to fight against cancer, we have to do it hand in hand, multidisciplinary team all the way. Sorry. Also, our partners in fighting cancer, friends from NGOs, patient survivors group, very happy to be welcome so many of you here today. Always my pride to fight by your side. No, I will not take much time just to tell you. I'm sorry, it is not COVID. Just to tell you a glimpse and introduce you into a context for this afternoon. As we all know that the cancer number is rising every year. From the global count 2020, the number of new cancer cases is over 19 million cases, with almost 10 million number of deaths. The most prevalent cancer are breast, lung, colorectal, and prostate, among the others. This to show the graph how is estimated to continue increasing to almost 30 million in 2040. In Indonesia, how is it? We have almost 400,000 new cases, and the highest number is for breast cancer, cervical, followed by lung, colorectal, and colorectal cancer. Our number is also keep rising significantly, almost 30% in 5 years. And unfortunately, 70% are still diagnosed at advanced stage. And it is also estimated as well to increase continuously, almost 70% in 2040. I'm sorry. As people who deal with cancer every day, I think we all know that cancer is a long journey. It involves many phases that we call the cancer journey, which needs to be treated in a continuum of care, starting with the prevention until the end of life care, and everything is important. We need to work together to provide the best cancer continuum of care. And it is mentioned that in fighting against cancer, the most important and the most effective is preventive. And the most effective is early detection. The most expensive is the diagnosis and treatment. And the other hand, palliative care is the most realistic. This just to show to prevent is better than to treat. And how important is the early detection can be seen also in our next slide. We can see here that what we need to do and what we can do is to shift our finding to the left, to find the cancer cases earlier and to treat immediately after finding it. Why it is important? Because the difference in the treatment response and survival rates is significant, and we can cure cancer when they high probability when we find it early. It is not only for the survival rate and treatment response, also for the cost. So yes, definitely we should do it. We can see here for breast cancer, for example, that treatment response for early is 90%, but it will become around 10 to 20% in the most advanced stage. So probably we already know all this. We do new thing every year. We try better and harder every year. But why many of you ask, the cancer number is rising up and not going down? What we all need to understand is that to fight against cancer is to aim for a win in the long run. We have to go through transition phase where it in the beginning more cancer will be detected. Actually, this is a good thing because people are more aware to get checked for cancer. So there will be more cases to be treated in healthcare facility. Then we will need more doctor. But after some years, we will see the benefit of the long run promotion prevention effort And only then the number of cases will start to go down. So in the beginning, in the middle picture, in the middle, the number of cancer cases who come to our facilities will increase significantly when we start to do the health promotion and primary prevention. And we will reach the ideal phase, which we call the hourglass phase, where most resources will be needed and allocated to promotion and prevention activities and for palliative cares. So we also adopted this way of thinking to the proposed framework of Indonesian Action Plan for Cancer Control to accommodate the hourglass transition from where are we now. This is actually true for many other countries. For example, here I'm showing from South Korea. When they start their NCCP into 1995, followed by establishing the National Population-Based Cancer Registry, a few years after, cancer number go up very significantly, and only after 13 years increase, it is started to decrease. So we have to be patient and have trust that it will be worth it in the end. Let's make the cancer journey easily accessible and with the same high quality and direction for everyone, everywhere. How? Before we begin our World Cancer Day event, let's hear Dr. Andrei Obaui, our speaker for today, who is the WHO headquarters focal point for cancer control. He is here with us to help us get our strategy on point. I'm very looking forward to hearing from him, and we could discuss later on with our key stakeholders, panelists. We have our Vice Minister of Health and Prof. Ari and also Ibu Liz from the Faculty of Medicine, University of Indonesia, as well as from the Cipto Mangunkusumo Hospital. Please make the most of this opportunity and discuss with all of here today. So with the theme is to close the care gap in cancer. So we have to know where are we and where to go. How big is the gap? How to fulfill the gap and arrange the strategy how to fulfill the gap. I hope today even will bring a new insight, a new perspective to help all of us in delivering our program. So my fellow colleagues, let's push forward more and better this year. We have many various activities planned. It is already collected by us, by our fellows, IRAS colleague, as well as I'm sure that our partner cancer NGOs all over the nation. We are looking forward to see every event, and good luck for everyone. So thank you very much.
Thank you very much, Prof. Tati, for your welcome remarks. And now we will move on to our keynote speech. But before we begin, may I kindly remind everyone, the participants, if you have any question, please type it in the Q&A box at any time during the session with your name and institution, please. And we will go through them during the discussion time. Or you could also click the raise hand button if you would like to speak on the open discussion session. And now may I briefly introduce our keynote speaker, Dr. Andre Obaui. Dr. Andre is a medical doctor, specialized and double board certified in surgical oncology. Dr. Obaui joined the WHO in 2015 and now serves as the acting technical lead for the cancer program at WHO headquarters in Geneva, Switzerland. And I believe that his talk today will be very insightful to all of us. So now to Dr. Andre, the floor is yours, please.
Thank you so much, Dr. Mayang. Honorable Vice Minister, Professor Tati, co-panelists, esteemed professors, leaders from civil society, friends and colleagues. Thank you really to IROS for the invitation to speak in this esteemed forum. Thank you also to Professor Tati, who set the stage so well to understand what is the gap we are trying to close, what are the lives we're trying to impact, and how we can make a difference together. As I begin, I would like to pause and just say thank you. It has been a very difficult past 2 years for the global community And we know this is also true for us in the cancer community. We have seen services disrupted. We've seen families that have suffered unnecessary consequences of being isolated and cancer treatments being interrupted. Many of you continue to work, in fact, are working harder in the front lines of the healthcare response to the pandemic. So thank you. We do hope that the years ahead will bring a promising new change, and we do believe that together we can deliver on this promise. In the next 40 minutes, what we will share is a better understanding of the cancer agenda as we look to 2022 and beyond. Here's how we will evaluate the three core topics. First, where are we now, and what is the exact context of cancer in the global situation? Second, what are some of the priorities that are emerging, and how can we better respond to them by already planning for some of the challenges that we will encounter? And third, what can we as WHO and you as key stakeholders do together to address this increasing concern in the public health arena? To begin, let us talk briefly about cancer. We know these figures very well. We all analyze them. We look at the colors. We wonder, is our country shaded dark? Is the burden higher? But in reality, cancer is a disease that affects nearly every family in the world, regardless if you live in Europe or if you live in Asia. To make it more personal, we like to present the data in this regard. For many of us living in Europe, we have a 1 in 2 or 1 in 3 lifetime risk. In other words, 1 out of every 2 people will be diagnosed with cancer in their lifetime, 1 in 2. That is a very startling number. For a primary care provider, a new cancer diagnosis may not happen every day in clinic, but across a country, it happens very frequently. It is a very personal disease. One wonders, what is the number in other countries? Well, in a country like Indonesia, it is not that different. In fact, it's close to 1 in 4 or 1 in 5 lifetime risk. Again, meaning that every country will be impacted, every family will be impacted, and every community will be impacted. As Professor Tati showed us, the burden is increasing and increasing rapidly. In Indonesia, it is no different. In fact, if we look at some of the cancers that are responsible for the burden of the disease, we see in breast cancer that it has increased by almost 25 or 30% in 8 years. And as we look to 2040, it will nearly double. So what does that mean? Well, first, let's start to understand why is this happening? Because this is, in fact, the beginning of a response. For us to be able to reduce the cancer burden, we should ask, why are the cases continuing to go up? And in some regards, it in fact is a success story. There are 3 primary reasons why the cancer burden can go up in a country. First, because people are living longer. Second, because populations are growing from birth rates. And third, because risk factors are increasing. But when we look at the situation, in fact, the story of cancer in some regards is a story of success in the other health arenas. We are now better at treating communicable diseases. We're better at treating maternal and child health needs. And as a consequence, people are living longer. And as people live longer, they're more likely to develop cancer. But what about the situation in Indonesia? In fact, it's very similar. There have been major improvements and progress in life expectancy in Indonesia. We see a reduction in birth rates and risk factors that are more or less stable. Now, this risk factors being stable does not mean that we could ignore that 30 to 50% of cancers are preventable, and we need to remain focused on that. But at the same time, we have to realize that one of the reasons that the cancer burden is increasing is because people are living longer. So in reality, we have to come to accept that the cancer burden will double in the next 20 years. For health planners, this is a major point for consideration. Let me say it one more time. The cancer burden will nearly double. So what does that mean? It means double the number of hospital beds, double the number of providers, double the number of infrastructure, double the amount of investment. That is a lot. We know that many governments right now are already struggling to meet the needs of cancer patients of today. The question is, how can we anticipate the needs of cancer patients for tomorrow, knowing that double of what we currently have, if not more, is needed to care for those populations? Let us remember again that it starts with prevention. What risk factors are responsible for cancer globally? Well, we generally group them into these 4 categories: behavioral, infectious, environmental, and other. When we look at behavioral, tobacco, alcohol, and obesity are the three big ones. Tobacco remains the leading cancer risk factor responsible for about 1 in 4 cancer deaths. So tobacco is a priority for all government policies, for clinical programs, and for population awareness. But infectious causes are also still a primary driver. They are responsible for about 13% of cancers globally, with the primary infectious agents being human papillomavirus, responsible for cervical and a variety of additional cancers, hepatitis, Helicobacter pylori, responsible for gastric cancer. But there are more. Environmental causes, air pollution is increasingly becoming relevant. And within the domain of the environmental exposure, this includes UV radiation, radon, and other aflatoxins. Genetics account for about 5% of cancers, but can be as high as 10% in some countries. But again, when we look at these numbers, we should understand the context in a specific country. Because comparing life for us here in Europe to life in Indonesia, the risk factors are very different. You can see that while both Europe and Indonesia experience high risk factor prevalence from tobacco, we have a high risk factor association with alcohol, not the case in Indonesia, but infectious agents are very common as a source of the cancer burden in Indonesia. So how do we adapt the global response to cancer, recognizing these variations? The second dimension of the current cancer response to consider is, are we on track to achieve the Sustainable Development Targets? As some of you know, there are two primary relevant targets. First, the reduction of premature mortality by 1/3 by 2030. The second is the achievement of universal health coverage. Again, we see great inequalities. When we look at high-income countries, they are making progress nearly on track. But for low and middle-income countries, the rates are more or less stagnant. And why? Well, we see again in high-income countries, it is a significant predictor of mortality differences if the country has universal health coverage and has a robust health system. And also we see significant differences between countries, differences that arise from factors such as education level, whether the person lives in a rural or urban environment, whether or not the person is from a lower or higher socioeconomic status. Now, these risk factors and these determinants are very important because we are seeing inequalities between countries, but we are also seeing significant inequalities within countries. And the short message again is we have not made sufficient progress to reach the SDG targets. So then let's start with this exercise. Why is survival so much better in countries that are high income compared to those that are low and middle income countries? We take Uganda as a baseline, comparing it to South Korea. A woman with breast cancer has about a 15 to 20% likelihood of surviving in Uganda compared to South Korea, which is 80 to 90%. In Indonesia, based on the data we have available, the survival probabilities are quite similar to what we see in other low and middle income countries like Uganda. So what is it that we need to do? Focus on early detection, focus on diagnostic quality, treatment complexity, treatment quality, or service coverage. When we break down each of these, we can see that their contributions to bridging that gap are all different. And there are in fact two primary focuses for us in the cancer response. First, the early detection of cancer. As we heard from Professor Tati, we see that 70% of cancers in Indonesia are diagnosed in the advanced stage when survival is very low. How do we respond to this? How do we improve that and ensure that people are having their cancers detected early? The second is, how do we focus on universal health coverage? In many countries, we see that only a third, a half, or even less are able to access cancer services, simply because the capacities aren't there or the financing isn't there. Investing in universal health coverage is the most important mechanism to bridge the gap. So how does that set us in the agenda moving forward in 2022 and beyond? To better be able to articulate or communicate with health policymakers why universal health coverage is so important, we did an analysis. We looked at breast cancer mortality trends, and we found that there were three general patterns that countries had. One is a pattern that we see in many European countries, listed here in green, pattern 1. These are countries that saw a progressive increase in mortality rates, and then in the past 20 to 30 years have seen a fairly rapid decrease in breast cancer mortality. Pattern 2, a set of middle-income countries that have been able to respond early. And pattern 3, the low and many middle-income countries that are seeing the cancer burden increase and progressively so. We asked, why is it that some countries have been able to bend this curve? We looked at 5 primary variables: whether or not they had universal health coverage, whether or not they had screening programs, whether or not they had national cancer plans, whether or not they had public sector cancer hospitals, and how much they spent on health. If we were to predict the 2 most important, all of them are quite relevant, but in fact 2 came out very strongly as the most important reasons why some countries are able to bend that mortality curve. Number 1, universal health coverage, and number 2, public sector cancer hospitals. Fundamentally, improving cancer outcomes is about improving service availability by reducing the number of people who have late-stage disease and ensuring that care is available. This doesn't require elaborate investments in technologies. In many situations, this doesn't also require elaborate screening programs. It is about the early diagnosis of cancer and ensuring that services are available to treat people when they're diagnosed. So what is universal health coverage and why does it matter? As mentioned, it is the most important mechanism to improve outcome and promote equity. And it also protects against the situations that we're seeing now, like in the COVID pandemic. Unfortunately, there is no other option. Investing in UHC is the foundation for success in cancer and all disease programs. So how do we drive UHC through cancer control? There are 3 dimensions to talk on now: setting priorities, investing wisely, and focusing on people. If we begin with why set priorities? Well, first, it's because all governments are constrained in how they spend money in cancer. This is true in Europe, this is true in the US, this is true in Asia. There are limitations in budgets, decisions have to be made, values should be prioritized. What we find is, unfortunately, many countries are prioritizing interventions that may not have the highest value for money. As an example, we started looking at a question like, is a country offering a screening program, but not offering financial protection against treatment? And unfortunately, it is very often that we see the situation, governments that are paying for screening programs, but will not pay for treatment. This is an inefficiency in expenditure. Ensuring that people have access to treatment is the beginning point of an early diagnosis program. Another inefficiency, to ask, okay, if they are screening, well, what age do they start screening? And unfortunately, again, when we look by income level, we see that the vast majority of countries are screening women who are too young, and again, resulting in inefficiencies in program development. So these types of questions, how do we set priorities in a cancer plan? Cancer plans do improve outcomes. They are the foundation for national response. But we do need to set priorities, and we must budget within those cancer plans. And when we do, how do we ensure that they're evidence-based and data-driven? The second dimension, how do we ensure then that the money that is available is spent well in all dimensions, selecting the right programs and direct to the right services? Well, again, we have to realize the starting point. Unfortunately, when we look at per capita expenditure in cancer, there is a significant difference between Europe and most low and middle income countries. Current expenditure per capita, meaning how much money is spent per population, per person in a population, is about $100 to $400 when we estimate what is spent for cancer. In many low and middle income countries, it is significantly less. So how do we take those fewer resources and allocate them wisely? To start, we must budget our plans. When we looked at cancer control plans, we found that less than 10% of countries had a mechanism to allocate a budget to their cancer plan. So stakeholders did this important exercise of developing a cancer strategy, but there was no budget that was allocated, no costing that was done, no financing mechanism in place. This is a major challenge in the cancer agenda. How do we ensure that we can cost our programs and develop those investment cases? When we are unable to invest, the consequence is that people pay out of pocket. We all know the situation, and we've been there with our patients, with our loved ones, with our community. If people are unable to receive care, then often we will go back to our communities, we will find the resources. What ultimately happens is that cancer becomes a generational cost, a push into poverty for many families. This is really unacceptable. A family is diagnosed with cancer, they live with the fear, they're harmed by the diagnosis, and to make matters worse, they have to sell possessions, pushing themselves, their families, their children into poverty simply because they have to pay for services out of their pocket. Now, how do we change this? This does not have to be the reality. Within WHO, we generated investment cases for countries, for the global scene, which is to say, we don't need $100 per capita to provide services for cancer. If we focus on what matters, we in fact can deliver an essential set of services at a very reasonable per capita cost. For example, a middle-income country like Indonesia can deliver a basic package of services at about $8 per capita and save thousands of lives in the years ahead. But when we look at where does that money go, this is again where we have to think about where the investments are made. If we say we are going to focus on high impact, radiotherapy for the most high impact diagnoses, systemic therapy using the most essential medicines, surgical interventions for the most impactful reasons, well, we start to see that if we do that, we can keep the cost at $8 per capita. If we start to include more expensive therapies, progressively that number increases, and we can see that the overall package cost can double or triple. And then we begin to wonder, are we achieving value for money? The beginning point is to understand what is the situation in the country. At WHO, we've reviewed every country's benefit package to understand, are they making the right trade-offs? And how can we advocate for increased funds? Because it is worthwhile to set cancer as a priority. We've shown you can save thousands of lives. The investment case is robust. But when we think about it, it's about, again, more people, not more goods. Making that trade-off, in fact, can ensure that we save lives. It is not an easy trade-off, but it makes the impact. Here's what it looked like in one of the countries where we worked. So in the country, we have a tool now at WHO and at IARC that can help countries make these decisions using data to inform that process of a national dialogue. So in the country, similar to what we know in Indonesia, they also had advanced stage disease for breast cancer. With the government, we looked at two possibilities: early diagnosis or screening. And in fact, you can see the difference in the investment. If we start with early diagnosis, the costs are less, the infrastructure requirements are lower, and the impact is nearly the same. After showing the government the exact details in a data-driven way, the government decided to focus on early diagnosis and also focus on increasing coverage for their cancer program. And they were able to do so by saving money by detecting cancer earlier and also saving more lives. So how do we invest in cancer? What are the priorities? Again, when we talk about infrastructure, this is important. And infrastructure investment should respond to the coverage needs. But at the same time, we should also be thinking about workforce. Workforce is a primary driver to increase capacity and to ensure quality. And the challenge is this: we know in many countries, like in Indonesia, we see a disproportionate number of providers to those who require care. While I was in the US as a surgeon, I could maintain a patient panel that was reasonable, 100, 200, 300 cases per year. But when I go to countries like Rwanda or Kenya or Guatemala and operate there, it's a very different experience. We see wait lists of hundreds, and what is the consequence? Their cancer progresses, and unfortunately, they ultimately have more advanced disease when they come back for their operation. So how do we respond? How do we deal with this when we are in a major generational event, this pandemic, that will have a radical impact on our health systems this year and in the decades ahead? Well, we're all thinking about this, which is, we know in the early phase, many countries have not yet seen an increase in cancer deaths just because of the biology of the disease. But in the next 5 to 10 years, we will see an explosion of cancer cases and an explosion of cancer deaths. What can we do? And what can we do to recalibrate our health systems for the midterm impact? We're going to see altered capacities related to service availability, financing, and products. So let's start again. Were we ready? Were we ready for the pandemic from an overall emergency preparedness and response? We know the answer. It has been a challenge for nearly every government around the world. We also weren't very well prepared as it pertains to cancer as part of essential health services. Most countries were unable to include cancer as an essential health service. Many governments did not dedicate a budget to cancer during this pandemic, and overall, the management of non-communicable diseases has suffered. So what are the strategies that we need to implement to ensure that cancer remains on the health agenda? Well, to begin, we also have to recognize that governments have made trade-offs and have understandably been focusing on the pandemic. Here's data from a country in Asia. We saw that their health budget immediately shifted towards pandemic response, towards vaccines, because that's what's needed. Now, the question is, what's going to happen with health budgets as the pandemic ebbs and flows in the upcoming months and years ahead? Will money for cancer still be available? We also know that governments are suffering economic downturns. This is going to result in overall less health expenditure. So how do we ensure that cancer is not forgotten in this during the pandemic and in the post-pandemic era? Let's start with an understanding of what happened. Well, we know that services have been disrupted in part because people feared going to clinics. They were unable to do so. They simply didn't present for care. But one of the reasons why services were also disrupted is because in the oncology community, many of us have been directly or indirectly affected by the pandemic. Being sick ourselves, dealing with loved ones that have been affected, being in isolation and or quarantine. Now, how do we make a health workforce plan that accommodates these realities? Well, in high-income countries, the disruptions have been managed by strategic modifications in workforce. In many low and middle-income countries, these are unplanned disruptions. Now, what can we do to address these workforce limitations? Here again are some of the data. When we look at oncology workforce differences between high-income countries and low and middle-income countries, you can see the ratio differences. They are quite significant. Now, in the pandemic, we see increased absenteeism. We're seeing increasing burnout. We're seeing increased retirement in some countries. And in fact, we expect that retirement will progressively increase in the year ahead. So the workforce demands are going to be great. And our workforce preparedness in oncology and in other programs is not where it needs to be to accept the reality that we will not be able to manage the cancer burden over the next decade ahead unless we invest in our workforce. There are ways to help bridge that gap. We've seen a lot of innovation that has emerged during the pandemic. Digital health has been used to support service delivery. And this is, in fact, the most common mitigation strategy that governments have been using during the pandemic, or reliance on telemedicine. It has shown significant value, but we have to keep asking questions. Is this sustainable? Is it working for all patients, or only those have reliable access to technology? Is it in fact going to provide the quality of care that we've come to expect and need in cancer? And a lot of these we don't yet know, but there are opportunities for us to start bridging that workforce gap in addition to the need to train more people. There are multiple optimization strategies that we can focus, not just on the only immediate response that people think of, which is train more. Yes, we need to train more, but how can we optimize the workforce more broadly? And then also to think about the broader impact of COVID. It has exposed people on systemic therapy, immunosuppressed populations to the increased risk of the virus. It has resulted in many essential services being disrupted. And of course, it has had a negative impact on cancer, both in its service provision, research, and innovation. Millions of lives we anticipate will be negatively impacted by the COVID pandemic amongst the cancer community. So what are we going to do? Well, to start again, focus on new service models, build workforce capacity, invest in UHC, and develop a new research and innovation agenda that meets the needs of all stakeholders. Now, UHC, this is a term you've heard multiple times in the past 30 minutes, but what is it going to take? Many of us hope that UHC can be achieved in months or years, but the reality is, unfortunately, UHC is a generational shift. We see that the initial concepts date back more than 5,000 years ago, and in many countries, it took decades to achieve universal health coverage. So it is important that we balance the need, the urgency, but we also can accept that we must be a bit patient. It took, for example, Germany 127 years to achieve universal health coverage. So how can we be both bold and patient? That's a question for us to think about in the cancer community. And also to ensure that progress we've made is not disrupted. We can see as an example here that COVID has also changed the face of cancer research and innovation. And perhaps in the end, that may be beneficial. Because when we look at innovation in cancer, most of it is focused on expensive technologies that are not yet accessible in most low and middle income countries. How can we reorient the cancer agenda to focus on the needs of countries like Indonesia? And this for us is an opportunity as we look to the COVID response in the decades ahead. For the sake of time, I'll be brief just to share with you some of the areas of work here at WHO and to invite you to be part of that work with us. As a starting point, we have a global program of work that focuses on country support. We're supporting now over 50 countries actively in developing their cancer programs, cancer plans, costing, priority setting, achieving value for money, workforce training, etc. We also have tools and guidance that is available to support governments, and we've created multiple platforms to engage stakeholders and governments. Here's the process by which we help governments, and for the sake of time, I'll just go to the next set of slides and share with you 3 initiatives that are in fact being taken up in Indonesia, and we appreciate the stakeholder buy-in and of course, and most importantly, the leadership and the commitment from the Ministry of Health. We have an initiative in childhood cancer, and again, thank you in Indonesia for taking this as an important priority and for the work that you've been able to achieve. Our goal is to improve survival, and we've been able to see progress in many of the countries that have taken on the cure-all approach. Here's some of the success that we've been able to achieve, including the achievement of universal health coverage for childhood cancer, or the inclusion of childhood cancer in universal health coverage benefit packages. We've been able to support workforce building, innovation, access to medicines. We have an initiative for cervical cancer. This for us is in fact a generational opportunity. We can be the generation that called for and led to the elimination of cervical cancer. In fact, the first and only cancer at this point that can be eliminated. It is achievable. And by making the right decisions now, we can see benefits for the decades ahead. Hundreds of thousands of lives saved each year in the years ahead. We've also just launched an initiative for cancer, the most common cancer globally, and also the most common cancer in Indonesia. So each of these, we use an integrated approach to support governments and build opportunities to develop cancer plans, to invest in workforce, and to deliver on the promise of universal health coverage. There's one other initiative just to share, because we know access to technologies has been such a challenge for so many countries around the world. Just last month, we announced with St. Jude Children's Research Hospital a new platform, a platform that will ensure that every child with cancer can have medicine without any fear of financial hardship and without any concerns for the quality, reliability, or availability of that medicine. It is a new platform that will in fact provide cancer medicines for every child around the world. This is something we can build on. We can build on this with radiotherapy. There are major opportunities in radiotherapy, with the International Atomic Energy Agency also planning to launch an initiative on 4 Feb that we at WHO are very pleased to support. The world is moving. There are new investments being made in cancer, and together we can achieve a major benefit for the cancer communities and for those affected by the disease. So here are the last 2 slides. What can we do concretely for impact? First, universal health coverage. What can you do as an individual? What can you do as societies? To ask one, is cancer included in our public financing system? Many may not know the answer. If it is, what interventions are? What medicines are reimbursed and why? Are there opportunities that we can save by shifting towards higher value for money investments? A question to focus on each of you as the thought leaders and brain trust as Indonesia can reflect on and ask. What is driving at financial hardship? Have we asked the people that we see in our clinics? Are you experiencing hardship? Are you experiencing psychosocial harm, stigma? If so, what can we do to help you? These are the investments that can in fact make a difference in the lives for people who are affected by cancer. Develop consensus on what are priorities across societies, across stakeholders, and support the indirect costs that many people with cancer are experiencing. Second, invest in people. Do we have a sufficient workforce? Is it optimized? This, of course, is the answer we know will likely be no. But what types of strategies can we implement? Can we ensure that competencies such as those for psychosocial support are being made available? If not, what can we do to support a national dialogue? We've done this in countries, and we've been able to build a strategy for the workforce, but it requires a consensus and it requires government buy-in. And then how do we train people to achieve the workforce competencies for comprehensive cancer care? And finally, how can we align and synergize? Cancer is not a disease in isolation. We are linked to almost every other disease program, non-communicable diseases, vaccines. How can we make those alignments strong? How can we sit with our colleagues across civil society, across professional societies, and see how we can help each other? This is something to think about because we appreciate the passion. The cancer community is without a doubt one of the most passionate civil society communities that exist, professional societies that exist. How can we build relationships that can foster joint interests? So let us work together. Let's do so with urgency, but also recognize that change does take time. Let's develop communities of advocates. Let's support each other because more than anything, cancer can be an incredibly isolating disease. For people, for the providers that are sitting at the bedside caring for those families, let's stand together, let's align and synergize. So is the cancer burden increasing? Yes, rapidly. We know that in countries like Indonesia, it's because of increasing life expectancy, and risk factors like tobacco should be addressed emergently. How do we reduce deaths from cancer? Focus on UHC, increasing access and quality. We're not on track, but we can make shifts. COVID is giving us a new opportunity to make those shifts towards health for all. And then what are we doing to respond? Well, we're working with you, we're working as an international community because we can make a difference together. We're very happy to have an opportunity to meet with IROS, with each of the professional societies here. It really is a privilege. So thank you for inviting us. Thank you for the time. Thank you for your passion. And we do look forward to working together in the months and years ahead.
Thank you. Thank you very much, Dr. Andre, for your very inspiring talk. Thank you. I really enjoyed it. And may I extend a very warm welcome to yang terhormat Dr. Dante Saksono Harbuono, spesialis penyakit dalam, konsultan endokrinologi metabolik dan diabetes, the Vice Minister of Health of Republic of Indonesia. Selamat sore, Dr. Dante. It is an honor to have you here, sir. And I am very glad. I think so. We have the most ideal panel with us here today. We have our Vice Minister of Health, and we have Dr. Lisdina representing our healthcare, and Professor Ari from representing our educational system, and even our friends from the civil societies are very much in line with the WHO priorities representing breast cancer, cervical cancer, and pediatric cancer patients. So thank you very much. And now we will start our panel discussion with our key stakeholders panel. But I'm very sorry, before we lose everyone, is it okay, Prof, if we first start with a photo session in the panel room? Okay, Dr. Dante, mohon izin ya Pak, kita foto dulu ya Pak sebentar ya. Iya. Iya dok. Iya dok, silakan.
Saya dari Dr. Dante, alhamdulillah.
Dr. Filbert, silakan dipandu untuk please give the sign for photo taking.
Dokter Sin, tolong kameranya.
Dearest Professor, doctors and guests, I will kindly request everyone to turn on their cameras, and I will start taking a picture after the third count. I would request that you would stay still for an additional 1 to 2 seconds following the third count. Okay, 1, 2, 3. Stay still. 1, 2, 3. Okay. Thank you, Doctor.
Okay, thank you very much. And now, please, Dr. Dante, mohon izin, we would like to invite you as our honorary key stakeholder panelists to give your expertise, comments, and discuss further with Dr. Andre here or anyone else in the panel room. Silakan, Dr. Dante, please.
Yeah, thank you very much for the committee to invite me for this meeting about the global oncology. But actually, I don't know, but because I prepared everything in Bahasa Indonesia. So it is possible I will deliver in Bahasa Indonesia with my slide. Okay, yeah. Please also help me to sharing the slide. Saya akan menyampaikan strategi dan prioritas penanggulangan kanker di Indonesia. Dalam hal ini bagaimana sebenarnya kita melakukan posisi kita di dalam penanggulangan kanker di Indonesia. Halaman berikutnya. Ada 3 hal penting dalam kondisi ini adalah yang pertama adalah situasi dan permasalahan kelainan kanker, kemudian upaya penanggulangan kanker secara nasional dan berbagai macam hal yang perlu kita perhatikan. Slide berikutnya. Bapak dan Ibu sekalian, kita tahu bahwa kanker merupakan peringkat kedua penyebab kematian tertinggi di dalam survei kesehatan tahun 2019, sesudah penyakit jantung dan stroke. Ini menjadi sangat penting karena ke depannya, karena selain penyakit jantung dan pembuluh darah, ternyata kanker juga kasus barunya serta kematian diprediksi meningkat dalam 20 tahun yang akan datang. Kalau kita lihat di tabel sebelah kanan, maka kira-kira kalau yang warna merah itu adalah mortality-nya, yang warna abu-abu muda itu ada insidence-nya, maka insidence-nya akan terus meningkat sejalan dengan mortality-nya. Dan kita lihat bahwa nanti tahun 2035 dan 2030 kita akan mendapatkan kasus hampir 5,5 juta orang dengan penyakit kanker dan 366.000 kematian juga disebabkan karena kanker. Ini akan terus meningkat sejalan dengan perkembangan mortalitas di kanker. Slide berikutnya. Bapak dan Ibu sekalian, di tahun 2020, 54 kasus kanker ini terjadi pada perempuan. Dan hampir 50% kasus baru terkanker pada perempuan itu adalah kanker payudara dan serviks. Kalau kita lihat datanya, bahwa kasus pada laki-laki itu terutama disebabkan, ada 183.000, terutama disebabkan oleh kanker paru dan kolorektal, sedangkan kasus pada perempuan sebagian besar disebabkan oleh kanker payudara dan serviks. Sehingga memang ini menjadi masalah prioritas yang penting untuk melakukan pendekatan secara tematik kalau kita ingin membangun sistem ketahanan terhadap kegiatan penanganan kanker secara holistik untuk menempatkan 4 prioritas ke insiden kanker ini sebagai tematik yang harus kita jalankan. Slide berikutnya. Tingginya insiden dan kematian dari 4 tematik kanker di atas itu menyebabkan pembiayaannya juga meningkat. Akibat pembiayaan yang besar ini, kanker dikategorikan sebagai penyakit katastrofik. Kalau kita lihat pada tabel ini, kita melihat bahwa tahun 2017 itu kita harus mengeluarkan 320 triliun rupiah untuk mengobati kanker. Kemudian biaya terus meningkat, tahun 2019 bahkan sampai 4 triliun lebih. Ini yang baru masuk di dalam data BPJS. Belum lagi termasuk dari data yang non BPJS. Kemudian karena adanya COVID, ini sedikit menurun, tapi saya yakin bahwa pembiayaan sesungguhnya itu sebenarnya lebih tinggi daripada 3,959 triliun pada tahun 2020. Sehingga penyakit kanker dengan pembiayaan sangat tinggi ini, itu dimasukkan ke dalam penyakit katastrofik yang menjadi prioritas untuk penanganan di masa yang akan datang. Slide berikutnya. Dan terlambatnya tata laksana kanker merupakan salah satu prediktor yang memegang peranan penting bagi tingginya kematian yang juga tingginya pembiayaan. 45% puskesmas melakukan deteksi dini. Kemudian 8,29 cakupan screening cervix cancer itu bisa dilakukan. Kemudian tapi pasien itu datang pada stadium lanjut. Kira-kira 70% pasien yang masuk pada ke rumah sakit itu masuk dalam stadium lanjut. Sehingga kemudian ditambah lagi dengan waktu tunggu untuk terapi definitif itu sekarang membutuhkan waktu kira-kira 5-15 bulan. Sehingga dengan masalah ini, maka sebenarnya hal penting harus dilakukan adalah pertama melakukan deteksi dini sedini mungkin, kemudian melakukan pembangunan infrastruktur yang menjamin bahwa waktu tunggu untuk terapi definitif itu tidak terlalu panjang. Bagaimana terapi definitif itu bisa dikerjakan lebih cepat apabila pasien itu masuk dalam stadium yang lebih dini. Kalau kejadiannya seperti sekarang, 70% masuk dalam stadium lanjut, maka pembiayaannya akan lebih tinggi, kematian lebih meningkat, terapi definitif akan membutuhkan waktu tunggu yang lebih panjang. Slide berikutnya. Bagaimana penanggulangan kanker secara nasional? Maka kita lihat bahwa kita punya komitmen untuk membuat transformasi sistem kesehatan yang Bapak Ibu semua sudah tahu. Ada 6 transformasi layanan primer, transformasi layanan rujukan, transformasi sistem kesehatan, transformasi sistem pembiayaan kesehatan, transformasi SDM kesehatan, dan transformasi teknologi kesehatan. 6 pilar transformasi ini harus bisa mendukung bagaimana kita melakukan capability building untuk meningkatkan layanan pada pasien-pasien kanker, baik mulai dari primer, rujukan, maupun sampai dengan teknologi kesehatan. Tentu ini harus berubah dan bisa diadaptasi secara keseluruhan di semua sektor dalam pilar transformasi kesehatan untuk bidang layanan kanker. Slide berikutnya. Dan kita lihat bahwa tahun 2022 sampai 2024 program prioritas pengendalian kanker itu difokuskan pada payudara dan serviks di layanan primer dan rujukan, serta paru dan kolorektal pada laki-laki. Ini kita masuk dalam program tematik kanker, dan itu mulai dari promosi, perlindungan spesifik, deteksi dini, dan kasus layanan rujukan. Dan kita mempunyai target seberapa besar volume itu harus ditingkatkan dari mulai kampanye tentang rokok, kampanye tentang kanker, kampanye tentang vaksinasi HPV, deteksi dini kanker payudara, dan layanan terpadu di rumah sakit rujukan. Dan kita punya target untuk sampai tahun 2024 untuk seluruh ibu kota, kabupaten, dan kota di seluruh Indonesia nanti tahun 2024 harus mempunyai kolaborasi di layanan yang terselenggara secara komprehensif seperti ini. Untuk kasus leher rahim dan kanker payudara yang kita harapkan turun dari 24,4% untuk kanker leher rahim sekarang menjadi 4% di tahun untuk per 100.000 penduduk di tahun 2040. Sedangkan kematian untuk kanker payudara diharapkan turun 2,5% tahun 2040. Slide berikutnya. Jadi beberapa hal yang penting dalam berbagai macam penanggulangan kanker di Indonesia adalah bahwa Indonesia memang masih dihadapkan berbagai permasalahan kesehatan termasuk penyakit kanker, dan insiden kanker tahun 2020 mencapai 397.000 kasus, 54% terjadi pada perempuan, dengan proporsi terbesar adalah kanker payudara dan leher rahim. Penguatan pilar transformasi itu harus dilakukan secara fokus, sehingga pertama deteksi dini lebih baik, kemudian waktu tunggu lebih cepat, dan terapi definitif lebih optimal. Ini dibutuhkan partisipasi seluruh pihak, baik pemerintah pusat, kementerian lembaga, swasta, NGO, organisasi profesi, dan masyarakat lainnya, dengan dimulainya kampanye faktor resiko kanker, vaksinasi pencegahan kanker, serta cakupan deteksi dini yang lebih baik. Mudah-mudahan webinar yang diselenggarakan pada hari ini itu bisa memberikan proyeksi dan pandangan yang lebih komprehensif bagaimana kita membangun sistem layanan kanker yang lebih baik di Indonesia. Terima kasih, itu yang bisa saya sampaikan, mudah-mudahan bisa bermanfaat untuk semuanya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Dante. Maybe I would like to ask if you have any comments, Dr. Andre, or the panelists here to Dr. Dante while we have him here.
Barangkali kalau boleh saya memberikan komen apresiasi kepada Dr. Dante yang sudah bekerja dalam waktu yang singkat untuk menyusun program penanggulangan kanker ke depan. Dan seperti yang juga tadi dalam presentasinya, intinya adalah bagaimana menggeser pasien kanker ke arah diagnosa yang lebih dini. Kan seperti itu ya Dr. Dante ya. Dan tadi juga kita melihat dalam presentasi awal bahwa satu-satunya keberhasilan penanggulangan kanker di suatu negara adalah kemampuan untuk menurunkan angka kejadian dengan tadi yang Dr. Dante sampaikan adalah dengan mengenal faktor resiko dan melakukan promosi untuk menurunkan angka kejadian kanker. Dan yang penting adalah bagaimana tadi yang Dr. Dante sampaikan adalah untuk menggeser temuan kasus kanker ini tidak lagi seperti yang ada saat ini 70% pada kasus yang lanjut dan lanjut lokal, yang membawa dampak terhadap terapi yang menurun sekali, keberhasilan terapi yang sangat menurun, akan tetapi cost-nya sangat meningkat. Itu yang menyebabkan tadi Dr. Dante memperlihatkan bahwa cost dari kanker, kalau nggak salah tahun 2020 atau 2019 sangat tinggi sekali. Itu karena mungkin juga pada saat itu kan pada saat mulai COVID ya Dr. Dante, yang kami hadapi di lapangan saat ini dengan masa COVID ini di mana pasien takut untuk datang dan terpaksa datang dalam keadaan terpaksa karena sudah tidak bisa lagi menangani penyakitnya. Jadi kita menemukan kasus-kasus yang besar-besar sekali yang mau tidak mau akan memberikan hasil pengobatan. Kita hanya bisa mengurangi simptom yang ada, akan tetapi tetap aja biayanya menjadi besar karena waktu perawatan yang lama dan sebagainya. Mungkin Ibu Lis lebih mengenal bagaimana keadaan di RSCM pasien-pasien kanker yang datang saat ini. Jadi apa yang tadi dipaparkan oleh Dr. Dante, saya sebagai salah seorang onkolog yang sudah cukup tua, sangat berbahagia sekali kalau itu semua kita bisa jalankan bersama, tentunya dengan prioritas-prioritas yang harus kita ungkit untuk memberikan dampak, akan memberikan dampak yang lebih baik dengan daya ungkit yang kita lakukan. Tapi juga di saat yang bersamaan kita menghadapi masalah-masalah kanker ini dengan adanya pandemi COVID. Terima kasih Dr. Dante atas paparannya. Dan terima kasih juga atas usahanya untuk para survivor, para masyarakat kanker di Indonesia. Terima kasih.
Terima kasih Prof. Bahwa sebenarnya apapun promosi yang kita lakukan, sebenarnya inti substansi dari promosi itu bukanlah sebagai program. Kalau promosi itu akan dilakukan sebagai program, baik ini kanker maupun penyakit lain, maka pembiayaan kesehatan pasti tidak akan cukup seberapapun besarnya untuk melakukan deteksi dini tadi. Jadi yang paling penting adalah bahwa promosi kesehatan tersebut seharusnya ditempatkan sebagai sebuah gerakan, bukan program.
Ya.
Gerakan inilah yang harus kita wujudkan di masyarakat untuk melakukan evaluasi, misalnya melakukan medical check up berkala, melakukan concern terhadap kanker ini secara intens dan sebagainya. Itu yang harus kita tumbuhkan di masyarakat. Seperti juga ketika kita menumbuhkan dulu posyandu dan gerakan BKKBN, itu merupakan dua contoh yang sukses di mana kegiatan promosi ini bukan sebagai program tetapi sebagai sebuah gerakan masyarakat. Nah, mudah-mudahan demikian pula untuk kanker, ke depan orang lebih menyadari bahwa deteksi dini untuk kanker menjadi sebuah gerakan inisiatif mandiri dari masyarakat, sehingga deteksi dini lebih ditemukan dengan kasus yang lebih cepat dan lebih akan mempunyai daya ungkit untuk masalah treatment dan pembiayaan yang lebih kecil. Terima kasih, Prof.
Ya, juga Dr. Dante mengingatkan, di antara kita nih ada wanita-wanita tangguh yang sangat bisa membantu gerakan masyarakat ini. Jadi ada baik Ibu Barbara dari Loving, kemudian Ibu Yanti yang tidak asing lagi dari CISC, dan Ibu Rahmi penggerak awareness kanker pada anak, yang tentunya nanti kita akan dengarkan, yang tentunya akan membawa warna bagaimana hand in hand dengan pemerintah agar gerakan masyarakat ini bisa berhasil dengan baik. Makasih Dr. Dante.
Makasih, Prof. Makasih.
Okay. Thank you, Dr. Dante, Prof. Tati, terima kasih. And I think now we will move on to our next panelist, to Ibu Lis, Dr. Lisdina. We are also very interested to hear your point of view as the director of the biggest and oldest hospital in the country. Please, Ibu Lis.
Bu Lis masih mute.
Kita, Prof. Ya, thank you, Dr. Maya. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Our honorable guests and distinguished speakers, Dr. Dante Saksemeherbona, our Vice Minister of Health, Professor Dr. Suartati Gondo Piajo, President of IROS, your incredible Prof. Dr. Andre Obaui, focal point for cancer program, WHO headquarters, Geneva, Switzerland. Professor Dr. Arif Aryasam, our Dean, Faculty of Medicine, Universitas Indonesia. Ibu Samantha Barbara from Lofting. Ibu Arianti Baramuli, Cancer Information and Support Center. Ibu Rahmi Adiputra Tahir, Yayasan Onkologi Anak Indonesia. Ladies and gentlemen, first of all, let's praise Allah Subhanahu wa Ta'ala for His mercy and blessings. Thus, we are able to attend this incredible webinar. On behalf of RSCM Director, I appreciate the IROS for holding this event amidst the COVID-19 pandemic. Cancer care remains one of the highest burden of diseases in morbidity and mortality, in social impacts, and also financially. As the top referral hospital in the country, Cipto Mangunkusumo acts also as the top referral center for cancer, which comes with many responsibilities. Cancer is our biggest load of patients in terms of patients number and also cost. Among these, 30% comes from Jakarta, another 30% from Java, and the rest of 40% is from outside of Java. There are 141 specialists from all over oncology departments. They are our best professionals from diagnostic, not only primary therapy, surgery, radiotherapy, systemic therapy, but also supportive and palliative therapies, such as nutritionists, psychiatry, medical rehabilitation, etc. Looking at the transition phases of cancer control towards the ideal hourglass, this is the awareness of the public and frontier medical doctors are gradually increased. So the number of cancer patients who come to the medical facilities are increasing, like in us. So we now experience a heavy burden to treat cancer patients, which still comes at advanced stages, especially in pandemic era. And therefore, we have to continually improve our quality and capacities we have. I believe the best team of multidisciplinary experts, the complete package of medicine and technologies, and we are always improving ourselves, including our personnel, always in search of new strategies to fight cancer through research in cooperation with the university. We try our best to provide best support for cancer patients, including providing rumah singgah of patients, dormitory, provided free for patients requiring accommodation during their long stay. We also work together with many societies in social projects to support cancer patients and survivors. To WHO, I would like to ask, what is the ideal referral system for cancer? We would be happy to welcome patients earlier than later. Is it direct or special referral system for cancer proven cost-effective and life-saving from the WHO evidence or analysis? Second, cancer registries, which is still a gap to be closed in Indonesia, needs to be solved. We in RSCM works to provide our comprehensive hospital-based cancer registry. To WHO, how can this data that we have to optimally utilize and regarded with the same quality as population-based cancer registry data? And again, to WHO and Ministry of Health, Bapak Dante, we would ask for full support to continuous improvement for our human resources, medical equipment, drugs, and infrastructures to provide the best cancer services for the Indonesian people in hospital. Thank you. That's my opinion, and so thank you so much.
Thank you. Thank you very much, Ibu Liz. May I invite Dr. Andre, please, if you could give a comment to Dr. Liz's questions.
Yes, thank you. Really, also with Honorable Vice Minister Dr. Dante on, just to begin by appreciating the leadership of Indonesia in the cancer agenda. And this often arises because of the highest level of political engagement from the Minister or Vice Ministers of Health. So thank you really to the Vice Minister for coming and for the enduring support. I also appreciate the important comments by Dr. because she raises the importance of comprehensive cancer care. And one of the areas that I did not speak to very much in the presentation is the importance of pathology. This was one that does require significant investment in order to improve the availability of cancer services for the community. So these are very important points to raise as we look at building capacity in a multidisciplinary manner and leveraging the investments in workforce that are required across the cancer continuum, from primary care providers through survivorship care.
Yes, thank you, Dr. Andre. Perhaps I would still would like to ask the Dr. Lee's questions on the most effective referral system that you know. Maybe the WHO have some data about it. Since
Yes,
you know, yeah, please.
I'm sorry, Dr. Liz, to respond to the referral networks. This is a very challenging question because there are no standard guidance that we can provide. The referral mechanisms that are required depend in large part on the distribution, the geographic distribution of population. And in a country like Indonesia, it is challenged, of course, because of the distance in which people have to travel. The way we advise governments is to start with an understanding of what are the case volumes in each institution and to organize services according to decentralizing services that could be offered in a secondary level hospital and centralizing complex services such as advanced radiotherapy techniques or surgical techniques. In order to do this, we do have evidence on what are those minimum thresholds. As an example, we know that certain hospitals should have at least 30 surgical procedures for breast care in order to reach a certain threshold of quality. So what we often recommend is we start with a mapping exercise to understand what hospitals are offering cancer services and to see, can we reach those thresholds and maintain services as close to home as possible. We do know that decentralization has to be balanced by cancer centers because cancer centers in general are able to provide higher quality care. But we also know that the further people have to travel in order to receive care, the more likely they are to present with advanced disease and or to not complete their therapies. So there is no perfect answer for how to set up the networks. But the two guiding principles are, number one, decentralize as best as possible. And this relates to the question on pathology, because this is one of the services to focus on decentralizing. So you have pathology and diagnostic centers that are close to home, and then you organize treatment services to reflect the complexities of services so that if complex treatment is needed, for example, in pediatric cancers, it is delivered at a centralized location. For more basic cancer interventions, like the management of early stage colorectal cancer, this could be done in a decentralized secondary hospital. So the focus is on defining those thresholds and balancing quality and access. So I'm sorry we don't have a great answer, but I would like to also reference that we are releasing a document, in fact, this week on how to build cancer capacity within cancer centers, focusing on the needs of cancer centers, because we see many cancer centers offer many of the services that are required, but not all. So this cancer center document will help provide guidance on how to organize cancer center and how to organize the service model.
Okay, thank you, Dr. Andre. Maybe another note that Dr. Lee also mentioned is about cancer registry. And because that we're still in development of our population-based national cancer registry, but we do, Cipto Mangunkusumo Hospital have its hospital-based cancer registry. And so Dr. Lee asked, how can we utilize this data that we have?
So this is also a very, very important question. Thank you, Dr. Lee. The first point to raise on registries is to, in fact, make them population-based. This does not mean that the starting point is every population needs to be covered, but where cancer registries exist, to go beyond hospital-based cancer registries and focus on covering a population in a specified area of a country, because that gives us more insight into the different parameters on the disease burden and on some of the points of access to care. When we talk about registries, we're also encouraging for a systematic decision to be taken on what indicators should be collected. Because historically we focused on what cancer cases with mild coverage for questions like whether or not the information being collected includes stage of diagnosis or treatment received, or whether or not treatment was completed. There are additional indicators that can be captured through a registry system that, when developed upfront, can in fact enable a more systematic evaluation of data for decision making. So registries are, yes, I in fact reviewed the registry situation in Indonesia last week while preparing for this talk, and I see that there is a strong commitment. In that regard, the question for this stakeholder group is to ask what data should be collected and focus on 3, 4, or 5 priorities. Again, such things as stage of diagnosis, treatment completion, type of treatment received, whatever you in the community think is most important. But to go also beyond registries, collecting only incidents. Incidents is very, very important. It is the starting point for policies. But since you have this increasing investments in registries, can we look at other indicators or parameters to focus on when building information systems in a more systematic way and linking it to the broader health information systems that exist in the country?
Thank you, Dr. Andre. Dr. Liz, do you have any further comments or questions, Ibu Liz? If not, maybe Dr. Dante, please at any time, if you would like to comment, please feel free to do so, Doc.
Yes, I think the cancer registry is also important for the future, because using the cancer registry, we can evaluate the condition of the patient, the character of patient, and also what we should emphasize the program for the cancer in the future. So, but it's difficult to make cancer registry from the primary healthcare until the others facility of treatment. So cancer registry is ideal, but is difficult to implementing. Sometimes difficult to implementing, but we should use that cancer registry to handle our program if we want to make our cancer program will be more aggressively in the future.
Okay. Thank you. Thank you, Dr. Dante. Now, I think we will move on to our next panelist. Now, we would also love to hear, of course, from the point of view of education and training system in the country, also a very important key stakeholder here. I would like to invite the Dean of our oldest and biggest Faculty of Medicine, Universitas of Indonesia, Professor Arif Fahrial Shams. Please, Prof, would you kindly share with us your thoughts?
Okay, thank you, Dr. Mayang, and also Dr. Andre, and our Vice Minister of Health, Republic of Indonesia, Dr. Dante, our President Director of Cipto Mangunkusumo, Dr. Liz, Professor Suhartati, our friends from NGO, Bu Rahmi, Bu Samanta, and also Ibu Arianti. So I will share. Can I share the slide? Thank you. Okay, so yes, thank you, Dr. Andre. You mentioned everything about how that we must do for cancer control. Okay, so it's mentioned that before I'm Dean of Faculty of Medicine, and also I'm Regional Ambassador for Southeast Asia of Association of Academic Health Center International. It is a great pleasure to me to give some talk in this important webinar, especially what is our role as a Faculty of Medicine here in Indonesia. I will start with our visions. Our visions from 2020 to 2024 is to become the center of knowledge, medical technology, and have excellent culture and competency through the effort of educate people to make our people prosper so we can contribute for Indonesia and the world. For to run these visions, actually we have some missions. As you know that we must give fast and equitable access for everybody for here to study in Faculty of Medicine. And actually, not only in our Faculty of Medicine, but also all of the institutions, medical institutions, especially also in medical institutions, need to implement qualified Tridharma activity, education, research, and service to people with relevance with national and global challenges. And to create high intellectual graduates, have noble character and can compete globally. This is the important things. And to create academic climate which can support UI visions. And to implement academic health system to build regional healthcare. Cipto Mangunkusumo is our main teaching hospital, and then we have some teaching hospital here in Jakarta. One of these is a National Cancer Hospital, Darmais. Okay, actually, so since 2019, we are a member of UICC. Okay, and we have actually now we have 46 programs, undergrad, graduate, postgrad, and doctoral student subject and some of our curriculum correlated to cancer. Okay, this is one of the example for undergrad module focusing on cancer, like hematology, oncology, introduced in the third year of medical school about the basic oncology, diagnostic, radiologic imaging, and treatment of cancer. Just only our students know about how to detect, how to know about the risk of cancer, and the important things, how to prevent for some cancer. And also, as a doctor in the future, they will detect the early cancer, something like that. And besides undergraduate, we have a specialty programs with competency in cancer management, like in the gynecology, pediatric, internal medicine, surgery, urology, ENT, neurology, radiation, oncology, that Professor Tati, one of our professor here, and ophthalmology, orthopedic, dermatology, and pulmonology. So our students in specialty programs also learn about the cancer in their study programs. And besides subspecialty, we have also subspecialty programs focusing on cancer, like gynecology, oncology, pediatric hematology, oncology, and internal medicine. They have subspecialty for hematology, oncology, and also surgery, oncology surgeon, and also orthopedic for oncology orthopedic. Here in Indonesia, specialty and subspecialty programs still university-based. So these programs start from university, and then we work together with some hospital for our students to learn or to take patient from that hospital. What is the methods of learning? Like, ambulatory patients, outpatients, clinic, inpatients, and then we prepare what we call a cancer problematic conference, and then some the student attached to the related department, and also we have research, especially in hematology, medical oncology, and other specialty which correlated with cancer topics. Yes, we also have collaborations. Like in these programs, we have what we call the female cancer foundations programs working together with Leiden University. This is the main programs is to early screening of cervical cancer. We have some international collaborations as well here. in some university. And then we have what we call that the double degree programs for international class program for undergrad. We are working together with Newcastle University, Monash University, and University of Melbourne. And our students make research in this university. Some they work in the cancer topics as well. And we have specialist double degree programs. So we send our specialists to University of Melbourne for Master of Clinical Research. And also some students work in the cancer topic as well. We have what we call it the Indonesians Medical Education and Research Institute, and then we have what we call it Human Cancer Cluster. Actually, this Emory was established in 2017 to create better healthcare and quality of life through disruptive innovations in medical education and research. We have 5 medical education cluster, and also we have 12 medical science cluster. And then one of best cluster in our Emory is a human cancer cluster. There's research on diagnostic, risk factor, and treatment at the level of tissue, cellular, molecular, and proteomics. And our human cancer cluster, the 3 research focus in breast cancer, colorectal cancer, and lymphoid and endocrine malignancy. This is our 2 publications. This is in the thyroid carcinoma, and then the other publication for breast cancer. So we developed one of herbal, what we call that lunasin extract for the prevention of breast cancer. This is some of our publications from our cluster, human cancer cluster. Okay, thank you for your attention. Back to Dr. Maya.
Thank you very much, Prof. Ari, for sharing your thoughts and about training, education system, and also research happening in the Universitas Indonesia. And please, in the panelists, if you have any question or comments to Professor Ari, please feel free to do so. Maybe Dr. Andre.
Yeah, thank you, Dr. Mang. Professor Ari, thank you. This is very, very, very impressive. And also most heartfelt congratulations on Emory, the innovative program. This is exciting to see, to build the infrastructure for research, implementation science in the country. It's really quite an achievement. Perhaps just 2 brief questions. As hearing you discuss the workforce and the specialists that are being trained, have you had a national dialogue on the types of competencies and the number of providers who are required to increase the oncology workforce capacity in Indonesia? And perhaps also to acknowledge that some of the competencies may be evolving in the era of increasing complexity of cancer care. So could you share, how are you approaching estimating the needs, both the number of providers and the competencies of providers in Indonesia for cancer care, that is, please.
Okay, thank you, Dr. Andre, for your question. So, yes, I mentioned that
May I interrupt for just a second? Dr. Dante, our 5 Minister of Health, I think Dr. Dante have another very important meeting. I'm sure that's why he has to leave us here. But I hope that with this communication, it's already open our window that we can do communication and do consultation for the further national cancer control program in our countries. So thank you very much to Dr. Dante. And
thank you so much for everybody.
We can most other communication in the future. Thank you very much.
Thank you.
Thank you, Doc. Yes. Okay.
Please, Dr.
Okay. Yes, okay. Thank you. So I will continue the answer the question from Dr. Andre. So I mentioned that our students yeah, for example, for our undergrad student, around 50% from outside of Jakarta, and also for our student in the specialist, I think around 70% from not from our institutions. So it means that they learn about to be a specialist. And one topic I mentioned that like internal medicine, they must learn about the oncology, medical oncology, and also hematology or something like that. And then around 70% after finish to be a specialist, they back to their hospital, maybe in the rural area. This is one, and also for the specialist as well. So we accepted around 80% doctor from outside Jakarta. So means that we increase the capacity building in the specialist and subspecialists. Subspecialists also like oncology pediatric, and also oncology surgeon, and also like hematologists and medical oncologists. Yes, and regularly we have a national meeting here, and then we sometimes use always take cancer topics to discuss. And also I mentioned that I'm active as a dean. We have what we call the Indonesian Society of Medical School here in Indonesia. So we are active in this associations, and then we have a national meeting as well. And then in that meeting, sometimes we raise about the cancer as well, because you know that our governments always mention that one of the biggest budget from government for cancer problems. So the important things how we working together to overcome this problem. So yes, so this is some my answer for your questions.
Thank you, really, and congratulations again.
Thank you very much for the question, Dr. Andre and Prof. Ari, for the answer. And because also Dr. Andre in his presentation many times has mentioned the importance of focusing on people and the workforce. So I think it is very crucial here, the role of our education system. And perhaps if I may reconfirm again, Prof. Ari, what Dr. Andre mentioned is, as cancer is very complex, and that it requires our doctors and healthcare professionals to have more and more increasing competencies, and also more and more in number. What is the strategy for our education system, or specifically Universitas Indonesia, to address these needs, and also the need to improve continually? Is there any specific strategy or program that you would design for cancer control?
Yes, thank you for your question. So yes, we know that actually in the nationally, actually we have still lack of doctors, lack of specialists and subspecialists as well. So that's why we must always increase our quota for doctors who want to continue to be a specialist, or specialist to continue to be a subspecialist. And also we working together, working together with other faculty of medicine. Sometimes we are, as a as a University of Indonesia, we always sometimes the first open for some study programs like subspecialist of orthopedy, and also for oncology radiation as well. So that's why we always encourage our staff in study programs to help other faculty of medicine to open their study programs, especially in the who work in the cancer, something like that. So this is some strategy how to increase numbers of human resources who will work in this area.
Dr. Mayang, maybe I can also say some word in this.
Please.
How
Please, Prof.
about the human resource development in oncology? So before graduated, whatever as a medical doctor or specialist or subspecialist, it is under the responsibility of the faculty of medicine in different university, as included the University of Indonesia. But then we as a professional society, you know that there are a lot of professional society in oncology like ours, Indonesian Radiation Oncology Society, or medical oncology, or surgical oncology, or ENT and Gyne Onco and others. We have our own continuing medical education program that we do to increase the know-how of our members to become more and more the knowledge and the skill will be more and more, and so we can have a very good expert in the field of oncology in different area of oncology. So usually we do it regularly, at least once or 2 times a year. And also for the medical, for the general practitioner, like what we will do for the World Cancer Day in the 4th of February, we will do a marathon webinar. What so-called the marathon webinar? So 3 days webinar with 10 highest incidence of cancer topics, and it is dedicated for the medical doctors, the general practitioner, and it will attend by more than 15,000 doctors, medical doctors. And the expert that will talk in that webinar come from our hospital. So that kind of activities, we do it regularly. And also I'm sure that from our NGOs, they also usually make regular activities to increase the knowledge and of the public as well as the medical professional in the field of cancer based on their region. That's what we can add. How to increase the skill and knowledge of the medical professional in the field of oncology. Thank you.
Thank you, Prof. Tati. Do you have further comments, Prof. Ari or Dr. Andre, perhaps? Right, if not, then may I move on to our next panelist. But I would like to invite first Ibu Rahmi. Ibu Rahmi from YOAI. Ibu Rahmi, please, if you could give your thoughts and comments to the panel, and Dr. Andre too.
Thank you, Dr. Mayang. In fact, I don't have any question, but in fact, I have a small message to Dr. Dante, but he is left already. So, okay, if it is allowed for me to speak up, can I?
Yes, of course.
Okay.
Silakan, Ibu.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Good afternoon, Dr. Andre Obaui from WHO, Dr. Lisdina Liastuti, my best friend, Dirut RSCM, kemudian Prof. Dr. Ari Fahri Alsyam, Prof. Suhartati, Ibu Samantha Barbara, Ibu Arianti Baramuli, dan Dr. Mayang sebagai moderator, Dr. Sinta juga sebagai sekretaris dari IROS. Thank you for giving me the opportunity to deliver a little message to this forum. My name is Rahmi Adiputra Tahir, Chairwoman of Indonesian Childhood Cancer Foundation, or known as YOAI. As we all know, the highest occurrence of cancer is the highest occurrence of cancer in children is leukemia, bringing a high percentage, around 60 to 65% in every hospital treating pediatric cancer patient in Indonesia. Chemotherapy drugs for cancer in children have also been guaranteed by the Indonesian Social Security Administration Body for Health Insurance, or known as BPJS Kesehatan. And for that, actually, I would like to appreciate Dr. Dante Wicaksono, but we highly appreciate the government's intervention in seriously handling the care of children with cancer in Indonesia. However, problems regarding the availability of drugs still exist. So on behalf of our foundation, Yayasan Onkologi Anak Indonesia, in fact, I would like to ask the government's attention, a little bit more attention to the unavailability of several chemotherapy drugs such as mercaptopurin or 6-MP, dactinomycin, methotrexate or MTX, lecorocin, which, although already included in the BPJS national formulary, are in fact very difficult to obtain, while these drugs are essential in chemotherapy treatments for children with cancer. So that's what my little message is. Once again, I appreciate the opportunity to speak in this forum on behalf of children with cancer patients in Indonesia. We do hope all pediatric cancer patients in Indonesia will be able to reap the benefit that has been provided by the government. Since every child with cancer, regardless of their status, deserve access to the best possible treatment and care. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Salam.
Thank you. Thank you very much, Burami. It's a very important message.
Yeah, please convey my message to Dr. Dante.
Yes, we will convey your message to Dr. Dante. Meanwhile,
thank you so much.
Dr. Andre, would you like to comment to Dr. Burahmi's note?
Yes, thank you, dearly, Ms. Rahimi. From your inputs, let us perhaps reflect again that access to medicines for all people with cancer, and particularly children with cancer, is a priority for the global community to respond to. I mentioned just briefly at the end, but we have spent 2 years now analyzing the market and the experience of countries like Indonesia to understand why are these happening? Why is this situation happening where medicines go through stock out, where medicines are being purchased by families and not by government agencies? And it is very common. And the challenge ultimately is, again, that the medicines become unaffordable or are substandard and purchased through unauthorized means. So just in December, we launched this new global platform with St. Jude Children's Research Hospital, in which we will allow any government participating to access medicines at a lower cost. And in this first phase, we're picking 12 countries in which we will be giving the medicines free of charge. So we will identify all children with cancer in the country, what the medicines are to treat those children, and they will be provided to the country free of charge. Now, this is the beginning. We hope to expand from 12 countries to more than 50 countries in the next 5 to 6 years. But we know that this will radically change the availability, the affordability, and the quality of cancer medicines for children, and in fact, also for adults, because it's the same medicine and the same formulation that are needed for adults as well. The program will focus on purchasing medicines initially for children only, and then we will work with governments to see how they can also participate in this platform so that they can access medicines at a potentially lower cost, and also to be assured that these are quality medicines that are being purchased through stringent regulatory authorities or national regulatory authorities. We'll also help governments with quantification. One of the things we often find are that insufficient quantities are being purchased. So there's medicines for the first 8-9 months. Then there's a stock out, an unexpected stock out because of fluctuation in volumes. So in the near future, we will have a solution, or at least we are working to a solution, because it has been a problem for decades that medicines, common medicines that are generic and should be available have been too expensive or unavailable. So we really are we're moving quickly, and we're happy to discuss further with you and with other stakeholders in Indonesia.
Thank you so much, Dr. Andre. Thank you so very much. Thank you so very much.
Thank you. Yes,
Thank you. Thank you, Dr. Mayang. Makasih banyak.
Okay, Bu Rahmi. So thank you, Dr. Andre. So I think it's very encouraging also the WHO global initiatives for childhood cancer, and we have been honored to participate under the leadership of Prof. Tati, our team in the childhood cancer network from the WHO Southeast Asia Regional Office. So I hope that in this year and the coming years, we will continue to make more activities and to help more children with cancer, together with Ibu Rahmi, and other many
hand in hand we go together. Okay, Dr. Mayang, thank you so much.
Yes, of course.
Prof. Tati, terima kasih.
Yeah, Prof, would you like to add something, Prof?
No, as it is mentioned by Mayang that we have a program with the WHO in South Asian WHO, with Dr. Gampo, focusing in the pediatric cancer, especially to help our friends in Timor-Leste. How to improve the quality of pediatric oncology treatment in that area. But again, the problem is the drug and facility. We can increase the knowledge, we can increase the skill, but we cannot help them to
since these drugs are the essential chemotherapy, Prof. Tati. So it is very important.
And leukemia is anywhere the incidence is the highest.
Correct. Thank you, Prof. Tati. So we are looking forward to hearing from you about the good news.
Okay, yes.
Thank you.
Mudah-mudahan ya Ibu Rahmi. Thank you
makasih
very
ya
much.
Dr. Mayang, makasih banyak. Makasih banyak.
Ya Ibu.
Dr. Liz, makasih Dr. Liz. Prof. Ari, makasih. Thank you, Dr. Andre.
Okay. Now we will move on to Ibu Samantha Barbara. Hello, Ibu. Please, may I invite you to give your comments, and you probably will have so many insights from the breast cancer patient survivors community. Please.
Okay, thank you so much, Dr. Mayang. Greetings to everyone, and especially for Professor Tati and all committee. Thank you for inviting us. Hello, Dr. Dr. Dante is not here. We do hope he's here, but I'm sure the committee will convey our message to him. Hello, Dr. Liz Dinalia Stuti, Professor Ari, Syam, all respected partners from other NGO, Ibu Rahmi, Ibu Yanti, dan especially Dr. Andre in Geneva. I'm glad to be here, and I'm glad that as a patient group, we are included to this kind of topic. It's very important for us to contribute and see from different sides from our journey. My name is Samantha. I'm a breast cancer survivor, Dr. Andre. I'm in remission for 9 years now, thank God. And I'm the chairwoman of the organization called LovePing. From several of your presentation, we understand that cancer could be prevented by avoiding risk factors and implementing existing evidence-based prevention strategies. And also the cancer burden could also be reduced to early detection and management of patients to be treated early, as mentioned from Dr. Tati earlier. And we all know that breast cancer is a major cause of disability, mortality among women. And that's why our organization only focus on breast cancer. And we've done education and support moral, empowering the patients since 2013. We've done the screening. So not only campaigning, we have done what Dr. Dante mentioned. We are doing all the activation through giving ultrasound since 2015 until to date. We have given 5,000 free ultrasound to mostly underprivileged women. And also we do education one-on-one, one-on-group, one to the community as the school, the companies, the factories, and we go around Indonesia and build our new organization in some respective areas. And also lately we have built our apps. This is about how to reminding to do your own breast screening. So it's not only for women, but it's also for male. What else? We have also formed collaboration. We know we cannot do it alone, and all the workers or social workers from at our organization, they are all survivors. And we collaborate with Ibu Yanti and also other 13 same organization, which is cancer mostly. So we can work together hand in hand and reach better compare if we are doing it alone. But in the reality, even if someone have insurance or they can go to the hospital, I think there are still a problem about screening, such as they're living far away from the facility, and also the care services problem. Maybe they don't recommend screening, and also the individuals is not really understanding cancer screening, how it applies to them. And you mentioned about the pandemic. This is also causing delay and fear going to the clinic. And also the big challenge you have mentioned also, Dr. Andre, Indonesia's geographic location. This is also a big challenge, how to distribute all the activation and all the doctors. So to go beyond, we need, of course, to work together. And I would like to ask you, from your perspective and your experience working with a patient group from other countries, what is your tips for us as a patient organization, so we can become the instrument and help our health system in strengthening the delivery and implementation of cancer control strategies, including how to close the care gap closely and lessen the burden, and then have access to our good access to our patient, access treatment, the drugs, and also responding to the situation. So I think that's it. We do hope we can work together, and looking forward to a better future and more oncologists in the field. Thank you.
Thank you. Thank you very much, Ibu Samantha. Please, Dr. Andre, if you would like to answer her questions. if you have some tips for, you know,
Yes.
I think it's a very important question for our friends
Very,
in the
very important question.
patient survivors.
Thank you, Dr. Mang. Ms. Samantha, thank you, really. It's, as we were briefly reflecting at the beginning, hearing the inputs from people directly affected by the disease, hearing from survivors is such an inspiration. It is a joy to see you, to see your strength, to see your smile, to see that you're healthy. So congratulations on your journey. Congratulations for your resilience and for your passion to give back to the community. So really, it's wonderful to see you and to be in this community where we can all support you and other cancer survivors and advocates. I think your question, there are three opportunities or considerations in the dialogue with civil society organizations. First is to ensure that priorities are shared. So how do we do that? As you know, in a country like Indonesia, you're developing a national cancer plan. First, it's to make sure you're at the table. So you should be, civil society organizations have an important role in the development of a comprehensive national cancer control plan. Once that's done, though, to also recall that the advocacy efforts should focus on shared priorities. What we often see is that some organizations come with new agendas, new opportunities, and while that can be useful, there should remain a strong consensus that we are going to take on a few priorities, because for us to make a major difference in the cancer agenda, it requires a concerted effort. The cancer agenda is so broad and it's so complex that if one organization does this and a small amount of change here, what we really should try to focus on consolidating efforts on shared priorities. So to be at the table and also to reflect on those shared priorities so that interventions have the maximal impact. But the second is to do what civil society organizations have done so well in many countries, which is to facilitate dialogues, because professional societies are very impactful. They often have good networks within ministries of health in particular. But as we all know, cancer is a disease that affects so many of us. So finding who are the legislators in the government who have been affected by cancer, who are your champions within all the halls of government. And this is something that civil society can do to bring those champions to the table, whether it's the heads of state or parliamentarians or other ministries beyond the Ministry of Health, to find out how can we support those advocates having a stronger platform, a stronger voice, and also making change in their own spheres of influence in the political realm. And then the third is to continue intensifying advocacy. There's no more powerful story for us in the cancer community than stopping to hear the journey of someone affected by cancer. We all have that immediate emotional response when we hear the story, like what you just said, Ms. Samantha, what we heard from Ms. Rahmi about the struggles of not getting medicine. When you tell those stories, they're provocative. We can't ignore them because it's so personal. We all could imagine being in that situation where our child doesn't have medicines. That would be devastating. I have two children. Someone comes and gives me that scenario, my heart just immediately moves. So to remember by keeping the people affected by disease in the front. And when we do that, also to realize that the narrative is a bit complex. As an example, we often talk about just what it means to be a survivor, the importance of being a survivor. But what are some of the other experiences they have? For example, we heard from both of you, the cost of care. The cost of care is very high. The cost of care is high, but not only for the person affected by the disease, by the family. So people, loved ones have to take time away from work. Children sometimes also have to participate in caretaking for someone who's sick from cancer. How do we take a step back and understand the full experience of people who have been affected by cancer? This is something we're working on at WHO. We're working in a few countries now to meet with survivors that are 10 years out from their cancer diagnosis and saying, what are the things now 10 years out that matter the most to you? And let us learn from that. Is it supportive care services, psychosocial support, indirect costs of care, transportation, adherence to therapy? For us to learn not just receiving care is important, of course, that key message is very relevant, but to make it also nuanced so that we can start doing more than just improving access. We can start meeting people with cancer through their full journey. So help us understand that journey. And that's the last request for civil society organizations. Beyond just let's improve care, but what else can we do to help? Because there may be other opportunities for us to change that experience, improve that experience. So really, thank you again, Ms. Samantha.
Thank you so much. Thank you so much. And looking forward to work with you and everyone in the webinar. Thank you. Thank you,
Yes.
Professor Tati.
Thank you, Bu Samantha. Now may I please invite our last panelist, but definitely not the least, Ibu Arianti Baramuli, our longtime partner, also very strong group from CISC. Please, Bu Yanti.
Thank you very much, Dr. Mayang. Good afternoon, everyone, especially Professor Suhartati, the president of IROS, and Dr. Andre Obaui from World Health Organization, Dr. Liz, the director of Cipto Mangunkusumo National General Hospital, Professor Ari, the Dean of Faculty of Medicine, University of Indonesia, Ibu Samantha, Ibu Rahmi, my colleagues, and also all the participants, my colleagues and friends. First and foremost, let me thank you for this opportunity to address such distinguished speakers and audience, and thanking Indonesian Radiation Oncology Society as the organizer for hosting this webinar. It's a very excited webinar. I'm Arianti Baramuli from Indonesian Cancer Information and Support Center Association. As a patient organization and as a cancer survivor, I gained valuable knowledge and ideas from the presentations of all the speakers. Thank you so much. In my opinion, our challenge now is how we could strengthen the collaboration between all the cancer stakeholders, included cancer patients, to accelerate the implementation of WHO global strategies regarding cancer control in a low and middle income country such as Indonesia. The Vice Minister of Health has explained the good quality cancer control plan in Indonesia, but in my opinion, it is far more effective if we have a National Cancer Control Committee. We all have seen the excellent work of NCCC under Professor Suhartati in 2015-2019. One of our organization's activities is advocacy. On November 2020, as UICC member, as well as a part of Indonesia Cervical Cancer Prevention Coalition, CISC supported the launching event and the WHO global strategy to accelerate the elimination of cervical cancer in 2030. We appreciate the Indonesian Health Minister, whom recently issued the Introduction HPV Vaccination Program. We hope there will be more policy to support cancer control plan. For instance, for hospice, we have not yet the policy. My question is, since we only have 8 years to go, what is the strategy from WHO and Ministry of Health to meet the WHO target of reaching 90% access to treatment for Indonesian cervical cancer patients, if I'm not mistaken, which includes access to radiotherapy? Furthermore, WHO also launched the Global Breast Cancer Initiative Strategy to reduce new cases and mortality from breast cancer. In Indonesia, early breast cancer patients with human epidermal growth factor receptor 2, HER2 positive, facing out of pocket to buy trastuzumab, since it is not covered by BPJS Kesehatan, even though trastuzumab is one of the essential medicine list. Please explain further, Dr. Andre, regarding WHO strategy on EML and why it is worse to be implemented in national level. And then how should the government ensure that there is a continuum of care accessible for the patients? As we know, Indonesia has implemented universal health coverage since 2014. A study found that UHC improves diagnosis, but increases delay of treatment. Dr. Dante already explained about this, but I agree that prevention should be improved. But what about the remaining? The remaining question is, how should we manage the who already detected, the patient who already detected? So related to bridge the gap, CISC chooses to put more effort on data advocacy and lay patient navigation hospital-based program to promote access to timely diagnosis and treatment of cancer. We are currently in training on patient navigation with Professor Suhartati and team as our trainer. And then we will launch a manual book for patient navigation. So please support us on this matter. Thank you.
Thank you very much, Ibu Yanti. Well, Dr. Andre, I'm actually very moved and impressed by all the important issues being addressed here by Ibu Yanti, Ibu Rahmi, Ibu Samantha. If we may, I know we're over time, but if you could please comment on these important issues that she raised.
I'm so sorry. I'm so sorry. I have another Zoom meeting. So, Dr. Andre, I'm so sorry. I'm going to leave now. Maaf ya, Dokter. I'm so sorry. Thank you so much. Thank you, everybody, everyone. Thank you so much. Nice to meet you all. Thank you.
Okay, please, Dr. Andre.
Yes, thank you, Dr. Mayang. And please, I'm also sorry for speaking and keeping all the participants for too long. So really, thank you for the time and the privilege. I'll try to be brief, but really, Ms. Aranti, your questions are so important. My goodness, what important insights you have brought to bear. So I'm sorry if my answers aren't long enough, but I really, really think your statements are so powerful. So briefly, you're first on the value of a cancer control committee. I completely agree. We have data now to support that without a monitoring mechanism, we cannot enable a successful cancer control plan to be implemented. So the monitoring includes what are the indicators that we should follow, who is in charge, so what is the governance, and without a steering committee or a cancer control committee, we are unable to maintain that level of monitoring and accountability. What we often advise, it's a general recommendation, let's say, is that the committee should meet at least once a year to involve all stakeholders, and there should be a report on the performance of the cancer program every 1 to 2 years. So that, again, it's not, here's the plan, we'll see you in 5 years. It's, here's the plan, here are the 10 or so general areas we will keep track of, and we will report to the steering committee every year with a brief, let's say, report that documents that progress. So I fully agree that's such an important point. The second is your comment on the 90% treatment target. I will be very honest, this is a challenging one, indeed a very challenging one, because we have looked at the pace in which we can scale up coverage. This is true for screening, this is true for vaccination, and this is true for treatment. In general, to be honest, it is difficult for governments to achieve higher scale up than 2% per year. This is based on some data we've looked at. It's not a formal WHO estimate, but 2% per year is a significant scale up of capacity. So within 5 years to get to 90%, if a country is starting with very low coverage, it's difficult because you need to train the workforce, you need to invest in these technologies, you need to ensure services are of high quality. Of course, you have to finance them. So it's quite difficult to go beyond 2% per year, but it's worth trying. And that's what the global strategy does. It sets ambitions for communities to move. So we should not forget the target. We should still have it in mind, but we can acknowledge that even if we don't hit 90%, it doesn't mean we failed. We should just make sure we're making good progress. So we will continue to march along. On out-of-pocket expenditure for trastuzumab. So this is a very sensitive topic because I agree, but trastuzumab is quite helpful for multiple people affected by cancer, gastric cancer, breast cancer, of course. And so the question becomes, when can it be most useful? Because if we're going to go to a government and ask for trastuzumab, we have data from other middle-income countries that one medicine can double or triple the medicine budget for cancer for the country. So what we recommend is who are the populations that will most benefit from trastuzumab, because it is absolutely important, for sure. It is a very high impact medicine, an essential medicine, as you say. But if we give it to everyone who could possibly benefit, then we will see that the cost could become so high. So with the government, we often say, let's start with a small set of indications and show that, okay, we're not going to pay for everyone who may need trastuzumab. We'll pay for a subset that will really benefit from it the most. Stage 3 HER2 positive breast cancer, as an example. They have a significant survival gain from the inclusion of trastuzumab. So it's about, let's start small, and then the government can say, oh, look, we're seeing it's saving lives, let's expand. But if we go and we say, we want trastuzumab for everyone, including gastric cancer, and it's going to cost double the health medicine budget for cancer, they'll come back and say, no, it's too much. So if we can start with what we think is highest impact and say, okay, we're committed to more, but we'll start here. And then the last is, this goes back to Ms. Samantha's question as well about what can civil society do. You raise navigation. Navigation is so important. So we don't have a lot of studies, but we have good data to show that navigation ensures timely diagnosis, it ensures adherence to therapy, it ensures a timely follow-up, and it facilitates referral back to the community, back to the primary care provider and center from which the person came. So patient navigation is very important, and advocates are the best navigators because they've had the experience. So for us, this is a very important activity for early diagnosis and to promote access to treatment, completion of therapy. And it's something that civil society can do very well. When someone is diagnosed with cancer, the best is to be linked back to someone who's gone through a similar experience. So really such important points. And I'm sorry, even 5 minutes I took now, but really thank you, Ms. Ayati. Very good comments.
Okay, thank you very much. Thank you very much. I know we're over time, and I wish that we could go on and on. And I'm very sorry, Dr. Andre and Prof. Doc, for Ibu for taking your valuable time more than we should. And so I think without further wasting the time, let's just, I would like to invite Professor Tati, Prof, to please give closing remarks to all of us this afternoon. Masih mute, Prof.
Thank you very much, Dr. Mayang. Thank you very much, everybody. So I cannot imagine that the discussion is take so longer time. That means we have a lot of problem, and that means that we focus, all of us here focus how can we fight to reduce the burden of cancer. Just to add to Dr. Andre, we have such kind of difficulties like our geographic. You know, we are the biggest archipelago countries in the world with 17,000 islands, more than 17,000 islands. And the second, you know, our population. And the third is our limited resources. And so we really have to have the priority. What is the highest burden? That if we approach that highest burden, it will show the good impact to the National Cancer Control Program. But we have also a strong point. We have a lot of NGO. What NGO that we showed today is the biggest NGO, but we have almost 50 NGO within the countries who are eager to work together to fight against cancer, to work together with the government and also with the academician, as well as with the medical services. So what I think what we have to do is we have to have the same direction, because together we will become stronger. Even there is, actually I have a question, one important question, actually continues to the question from Ibu Liz. Ibu Liz was asking about referral hospital. What do you think, Dr. Andre, before we left us for today? Since that 70%, I'm a clinician, since the 70% of our patients are locally advanced cases, so maybe more than 50% of the 70% are cases with the best supportive case patients. Do you think is that better to have the hospital special for best supportive care, just only to support the patient, give a good good quality of, let's say, good quality of die? Because otherwise, like what Ibu Liz mentioned, like for example, Cipto Mangunkusumo Hospital have a high technology of treatment, but nowadays the place are occupied by the patient for the best supportive care patient. We cannot send them home because the home care in our country is not yet really good. So that means the patient have to stay in the hospital and occupy the place that actually we can treat the early case with the high technology. Maybe that's one thing that's still in my mind. I don't know. You will give it the comment today, or you can send me email to answer that question. But anyhow, we would like to thanks to Dr. Andre for your really good information that you give to us, and it is make all of us open our mind, and also make our communication in the future can be better, and you can advise us what shall we do, because we have limited resources and limited time with such a big problem in cancer, such a big burden of cancer. Thank you very much.
Thank you. Thank you very much, Prof. Tati. Thank you very much, Dr. Andre, and everyone here, Dr. Leeds, Prof. Ari, Ibu Samantha, Ibu Yanti. Thank you very much. It has been a very powerful discussion this afternoon. It's a pleasure, and I hope, Dr. Andre, you and the WHO will continue to support us and work with us in the future.
Thank you.
To everyone, stay safe wherever you are, and hereby we will close the webinar session. Thank you.
Thank you so much, everyone. Stay safe.
Thank you.
Stay safe. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you.